Any question? Oh, I was saying the case studies, you just take it. No need to send me anything. I see the report right away. It generates the report. So nothing to do on your part. All I need are your your Saunders, the 25 question Saunders every week. Please send those. If you forgot to send it this week, that's fine, because I'm not recording it based on when I received it, because I can see the date and the time that you did it. So don't worry if you forgot. No, things happen because you're busy, especially come exams. You just forget to send it to me. That's fine, as long as it was done when it's due. I'm grading you. One last thing, how are you graded? Well, you're not graded based on your score. So let's say you got 60% on that Saunders test that you took. That's fine. I looked up the HESI submission that you did. I look at the remediation time. Does everybody understand what is remediation?
No.
When you review the test. So let's say you're on Saunders, right? So here, so let's say you review this one. Okay, so so you scored 2%. Okay, so you click review, and then you review the items that you didn't get correct. Well, this one only displays one because I only took one question. So of course you will have several. So when you do the remediation, it logs the time. You can't see it, only instructors see it on the instructor view. Students have no way of seeing, meaning your history here. All it will display is the date, the time, the number of questions, and that you completed or suspended it. But on the instructor view, when I look at it, it will give me the details on what you did afterwards. Okay, so I can see the total time that you spent on it. So the expectation is you do 1 minute of remediation per missed question. So let's say you made a 25 item test and you scored 50%. So half of that I know is at least 13. So I need to see 13 minutes minimum there of remediation. If I don't see 13 minutes, I will record a score. So let's say you scored 2% on this one because you're short on remediation. I won't give you 100 for the week. I'll record that score that you got. Whether it's 2, 30, 60, that's what will be recorded for that week. But if you do your remediation like you're supposed to, 1 minute per missed questions, no questions asked. If I see that, you'll get 100 points for that week on Saunders. Any question?
And Professor, this only applies if you have like questions wrong. Let's say you have a perfect of 100, no remediation is required, right?
Yeah, if it's 100, then what's there to remediate? Any other question?
No.
All right. So let's finish this. So we did. So all right. So I explained to you how to submit the weekly Saunders. For case studies, just do them. and no need to submit anything to me. Same thing for these two here. I will put on week 13 because they're technically the tickets to test for the specialty. You have 2 attempts at it. You need 90 as to score 90% or better. So you can easily get that 90. Of course, the only objective scores are the unit exams, the quizzes, and the final. All these other guys here, Saunders case studies, and the 2 tickets to test, they're all, right here. So these, which are only 10%, okay, 10% are all going to kick in once you reach 78% on the objective scores. So once your unit exams, quizzes, the final, and the specialty score all reach, all total to at least 78% or better, then final course grade will include these. Right? If not, then 0 will be entered for the 10 points. And that might bring your 77.9 down to D. Okay, maybe I think you'll end up with a 60 something. Any questions? So that's how the course would be graded. And again, very easy topics from endocrine all the way to shock. Questions, ladies and gentlemen? You're too quiet.
Professor, I have a question. You said that the specialty exam would be considered this semester and it wasn't considered last semester. It was optional. How soon in advance will you know in order for you to notify us that we're having the specialty exam?
You will be the third persons to know. Once admin tells me, I'll tell you.
Okay, so not maybe like in the next 6 weeks, the next 8 weeks. That's what I was kind of trying to measure. Not so much in what order, but in what weeks, you know, is this something that might come up in the next month or the next 6 weeks where you'll be able to tell us so we have enough time to prepare?
Yeah, that would be a great example of a question that I have no answer to today, unfortunately.
Okay, thank you.
Ask the dean. I don't think the dean knows either. See, the issue with specialty exams is they do not allow schools to administer it if they don't trust the proctor, meaning the proctoring system. With these artificial intelligence proctor softwares like ExamSoft, iProctor, they have been validated that they are reliable. Even with the Zoom proctoring that we were doing, it's not really 100% because although we see you taking the test, you're muted, so we really don't know what's going on, you know, in your surroundings. So the publishing companies who write these standard tests are aware of that. So that's why they never allow that. We were unable to administer the specialty tests because they do not want them compromised. So they, unless it's 100% guarantee, then they won't settle for anything less proctoring wise. Any other question before we begin?
Hi, Professor. Regarding the case studies, are you going to open everything at once or you're going to open it per time?
No, I'll open. Just give me until the end of tonight.
And we can do them all at once and just have them.
It's up to you. Just a warning though, should you decide to do them all, I mean, it's no, there's no time limit to it though. You can take as much time as you can. It's basically open book. But because it's open book, there's only one shot at it. It's only one attempt. It will be set to 2 attempts. You'll see when you click on it, it will say 2 attempts, but I'm only recording the first submission. I only put 2 there because there are instances wherein it's clearly a, you did it halfway and then something happened, the internet turned off and then you didn't get to finish it. So I understand those, but only the first submission will be recorded. So let's say you tank the first one, right? The first submission, you tank it because it shows you the answers already. So if you do that and then you get 100 on the next attempt, then I will only record the 0 that you got the first time.
Got it. Thank you.
At least with the others, I can see nice pictures. Like I can see Beija's little baby there, and Zahida's very nice. This looks like a Instagram profile. Miss Selena and Tiara, wearing a tiara. Very nice. But you, I will see you later, the rest of you, because we have the dosage calculation quiz, which is the first of up to 3 attempts. You need to score 100 on that, by the way. If you don't get 100 the first time, there's 2 more attempts. It will be on Jupiter. The types of problems on it, nothing different. Same things you did in 103. We will have basic oral medications. There are injections, parenteral questions. We have weight-based calculations, like how many milligrams per kilogram. So that's obviously for pediatrics or for maternity patients. And then we also have IV infusions, which is basic IV infusions, how many mLs per hour. It will also cover heparin infusions and also weight-based critical care infusions, like dopamine infusions, for instance. Like how many milligrams, the doctor orders to give so many micrograms per minute or per hour. And then you have a bag, you simply calculate how much will you infuse mLs per hour. Questions, guys?
No, Professor, but this is my little baby now. He's a big boy.
Yeah.
Say hello.
Hi.
Hello, buddy.
Hello.
All right, so if you know questions, let's take a short break. Come back at 1:20 p.m.
Okay, thank you.
Thank
All right.
you.
In the same code.
Okay, Professor.
Same code, right?
Okay, let's begin now. This part will be a review because you did hypoglycemia and so I'll just go through this one quick. let's start with table 64-12. So comparing hypo and hyperglycemia. There are 3 acute complications of diabetes. All 3 are life-threatening. Among the 3 though, hypoglycemia is the most life-threatening. The other 2, which are HHS and DKA, are both hyperglycemic episodes. I'm not saying those 2 are not life-threatening. They are. In fact, those 2 will lead to shock. However, hypoglycemia is equally, or if not, more life-threatening compared to the other 2. So here are the differences between the 2. They are mostly separated by neuroglycopenic symptoms. Okay? Of course, hyperglycemia will have dehydration, then there is none on hypoglycemia. Most of the symptoms, as you can see, are compensatory symptoms, meaning they are the signs that your body is compensating, particularly sympathetic nervous system stimulation manifested by increased heart rate. That's why you have tachycardia. And then because there is generalized vasoconstriction, that's why the patient's skin feels cool and clammy. And like I said, there is no dehydration in hypoglycemia. This part here might help you remember. So again, because it's life-threatening, not only will you have adrenergic symptoms, which are your sympathetic nervous system response, but also in your neuro symptoms, simply because the brain consumes 25% of your blood sugar levels in the body. So it's only fitting that it will also manifest the most symptoms. The signs and symptoms vary per individual. We will go to the chart comparing the different levels, because there are 3 levels of hypoglycemia. We have mild, moderate, and severe. Please review the potential causes. This might come out under the prevention question. So let's say, the question goes, how do you teach a patient how to prevent hypoglycemia? So this will be the answers, because since they are the known causes of hypoglycemia, so therefore they will be part of your prevention plan. Interventions, there are temporary interventions, like for instance, giving glucagon injections, subcutaneous or IM, or giving IV dextrose intravenously. But the really permanent fix is feeding the patient. All right, so these are, please bear in mind that these interventions we're reviewing are only temporary fixes. Okay. Are you with me so far? So quiet again.
Yes, Professor, we are here.
Are you still live? Okay.
Yes, we are here.
All right. So chart 64-7. This is at home. And then the paragraph following this will be your interventions in the hospital. Obviously, there is no IV in at home, so you will be left with, especially if the patient's already unconscious and unable to take anything by mouth. So that's why you need the parenteral interventions. Although this is labeled for the home, we do the same in the hospital. So we follow the 15-15 rule. 15-15 stands for giving the patient 15 grams of carbohydrates, follow on, as well as checking the sugars every 15 minutes. So for mild, these are the common symptoms during the mild, and by saying mild, we mean a blood sugar of less than 60, but still above 40. Okay, so you can say this is between 40 and 60. So these are the choices. We're not giving all of these. We're giving one each. So you either choose 4 cubes of sugar or 6 saltine crackers or 3 graham crackers. Each one of these are equivalent to 15 grams of carbohydrate. All right. And then if the patient's sugar is now between 20 and 40, that falls under moderate. The patient's symptoms are now the following. So we go from 15 to double now. We go 30 grams, which is double the amount of these, or you give 2 of any of these combinations, right? So that should satisfy 30 grams of carbs. Now, finally, for severe, which is now less than 20, now most patients here are now unconscious, therefore unable to swallow. So that's why it would make sense that your interventions are now parenteral. So you give either a milligram of glucagon, so that's given either IM or sub-Q. This obviously is in either a pre-filled syringe containing 1 milligram of glucagon, or the patients have to draw them up. So the kit will have a vial, 1 dose vial of glucagon, and then a syringe. Give a second dose if the patient remains unconscious after 10 minutes. In both cases, though, you will have to notify the physician about what happened because this is not safe. So we may be lucky because we were there when the hypoglycemic episode occurred. What if we're not there next time? So the patient and the doctor needs to agree on, they need to investigate how did this happen. So we will investigate what caused it. So is it a user problem? Maybe we did the insulin administration wrong, or maybe it was the patient's fault. Okay, maybe they did not eat, right? Or maybe there are other complications now, which is, let's say, this one, because the patient may not be aware of the development of gastroparesis. Gastroparesis is a neuropathic complication of diabetes resulting in low peristalsis. Therefore, there will be delayed gastric emptying now. So, for instance, if the stomach normally empties 1 to 2 hours after eating a meal, and then which is great because we have insulin lispro also peaking in about 1 to 1.5 hours, there will be no hyperglycemia because the timing of gastric emptying coincides with the timing of the peak action of insulin. However, if the patient has gastroparesis, wherein emptying of the stomach now occurs 2 to 3 hours instead of the normal 1 to 2, by the time insulin peaks, there is no spike in blood sugar yet because the stomach hasn't emptied into the duodenum yet. That will therefore result in a dangerous hypoglycemic episode. One word of caution is patients tolerate hypoglycemia differently. You'll see patients who are unconscious at a blood sugar of 50. And I've seen a patient with a blood sugar of 25 walking around. So depending on the scenario, you should choose the appropriate action. Meaning, although these are what's recommended, so let's say for mild, these are what you give. And for moderate, these are what you give. You double what you were giving in mild. And then finally, you give parenteral injections for severe. Now, it really depends on what is your patient's status. If a patient is unconscious at 50, of course, you're not going to force 6 to 10 hard candies down their throat. The patient's unconscious. And in the same way, even if the patient sugar is severely low, but they're awake, they're able to eat and swallow, follow directions, then you can also give them the PO interventions. Is that clear?
Yes.
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 All right, for drug therapy, there are precautions here. These are now your responsibilities. So this would answer questions about what will you do when administering glucagon, for instance. So you know this drug causes nausea, vomiting. So therefore you have to take care to institute aspiration precautions when giving glucagon. Sorry if I induce nausea there. Okay, so again, I already said this earlier. Glucagon and dextrose effects are temporary only. Both are not permanent fixes. Okay, your only permanent fix is to feed the patient at regular intervals. All right. Any question on management before we go to HHS and DKA? All right, very good. Please read the prevention on your own. These are again the practical examples of the bullets I showed you earlier. Now this covers about exercise, timing of food, and then alcohol. Okay, and then proper administration of insulin. Okay, those are practical examples there.
Professor, I have a quick question.
Mhm.
These notes that you're right now showing us, are you going to post it on the Jupyter? Or,
What am I posting on Jupyter? I'm sorry.
I mean, the notes that you're right now teaching us, those notes, are you going to send it to us?
This is your textbook.
So everything is in the textbook, right? These are from textbook.
I don't use PowerPoints or notes. Because you have the textbook, I'm using the textbook. So I'm forcing you to use the textbook.
Oh, okay, no problem.
Alrighty. But I will upload the links to the class if you need it. Okay, I'll upload each session to YouTube, and I'll send you the link.
All right,
Yeah.
thank you.
Thank you.
Thank you.
Okay. So we have two hyperglycemic acute complications here, DKA and HHS. DKA happens to both type 1 and type 2. HHS only happens to type 2 diabetics. Over 20 years ago, during my time, the textbook still said that DKA only happened to type 1. And
Professor, 1 minute. Which page are you on?
1311.
Okay.
So during my time, which is over 25 years ago now, our textbook still said DKA happens to type 1 only. HHS happens to type 2 only. As you can clearly see, diabetes evolved. That was no longer true. Now we're seeing type 2 diabetics experiencing DKA. Now that doesn't mean they have now become type 1. Okay, that is not the case. It just means that the type 2 diabetics now are getting worse. So therefore, there are instances wherein they can develop either DKA or HHS. The risk factors or the events leading to both are exactly the same. So the patient either got sick, had an emotional stressor. So let's say Miss Beja, for instance. I told Miss Beja that I'm not seeing her anymore. Miss Barona, how did that make you feel?
I was so devastated, Professor. How could you do that to me?
Okay, so that would be a severe emotional stressor. Okay, environmentals also, let's say you are in a very hot environment or very cold, for instance, or you're in a war zone, whatever that is. Okay, so you are exposed to a severe stressor. And what is the effect of having a stressor, any type of stressor, whether it's physical or emotional or psychological stressor? What happens to our blood sugars?
It goes up.
It goes up.
Always goes up. So especially if somebody is sick. Now, let's go to the prevention first before we discuss the differences as well as what happened, the pathophysiology. Let's look at the prevention first. So it's covered under chart 64-8. This is page 1314. Since this condition, we'll just call them sick day rules, where we don't have to be literally sick. Okay, it could be, you can also change this to if you are under stress. Example is, let's say you're like right now, does it feel stressful starting class over the summer in a completely different
Yes.
Yes. Come exam time, so you know you have a quiz next week, or worse, you have your first exam on June 1st. Does that feel stressful?
Yes, of course.
Yeah.
So whether you're physically sick or emotionally or psychologically sick, you follow these rules. Okay, so this is both for the family and the patient. So when you're sick or under stress, these are what you do. So you continue monitoring your blood glucose, maybe a little bit more frequent than you used to. Let's say if you're only used to taking your sugar 4 times a day or 3 times a day, maybe increase it to up to 6 times a day now. Test your urine for ketones. We no longer are dependent on the laboratory to send urine there to test for ketones. We have over-the-counter urine ketone kits available in any pharmacy. They're not that expensive, or you can also have your insurance company cover it. So these are emergency kits you can do safely at home. So if your urine tests positive for ketones, then you call your physician. Continue to take your insulin. Of course, you have to check your sugar before you administer insulin or your oral anti-diabetic pills. And stay hydrated. Okay, do not stop drinking. If you get to a point wherein you can no longer eat anything by mouth, let's say even fluids you cannot tolerate anymore, then it's time to visit the hospital. But as long as you can stay home. Okay, it used to be whenever we had positive ketones in the urine, every patient was admitted to the hospital. That's not really necessary nowadays, especially today in this day and age wherein we're dealing with COVID. It's not really necessary to admit you to the hospital. Okay, as long as you can keep some fluids down, we don't have to admit you to the hospital. However, if you have these now, so your ketones in the urine are now large or moderate, and you're already technically sick, okay, so you have a high fever, then you cannot be managed at home anymore. So it's time to call your physician, okay, and most likely he'll tell you to go to the ER already. Question on prevention. So some patients who are undereducated on diabetes, the common belief is if I'm not eating, of course my sugar will drop. Is that true?
Not always.
No, it's not true, because remember, we can literally eat ourselves to death. Okay, we have plenty of carbohydrate stores in the liver. We have glycogen. In the fat, we can turn that to glucose. In our proteins, we can break down muscle, turn it into glucose. So we're literally made of sugar. So we have other sources of sugar besides food. So it's important that patients know that in times of starvation or in illness specifically, it will cause our blood glucose to rise. You'll see this again when we go to sepsis later in chapter 37. You'll see that a patient with sepsis actually develops hyperglycemia because of the amount of stress and sympathetic nervous system stimulation. All right, let's go now to DKA first. Before I start with the pathophysiology, let's compare both using table 6413. Both are hyperglycemic episodes. Both are precipitated by the same thing. The patient with diabetes, whether type 1 or type 2, got sick physically, emotionally, or psychologically. So we had a stressor which started the hyperglycemic vicious cycle. All right, onset. DKA suddenly occurs. By suddenly, we mean literally a few hours. HHS, on the other hand, is gradual. By gradual, we mean several days up to a week. Because DKA is sudden, most of the symptoms are acute and therefore readily observable. In HHS, they are subtle, which makes HHS very dangerous because look at the symptoms. The patient has altered nervous system function. So show me what the patient looks like with altered CNS function. Tell me what this patient.
Confusion, dizzy.
Okay, so when you're confused, are you aware that you're confused?
No.
No. Possibly these patients will also turn sleepy and then they'll just go to sleep and never wake up. In DKA, because the symptoms are acute, the patient notices the change, especially when ketosis kicks in. We'll look at how the body develops ketosis shortly. Look at this. The patient has Kussmaul's respiration. So you learned this in chapter 11 under acid-base balances. So this is a compensatory mechanism. So when the blood pH becomes very acidic, the response by the lungs is to eliminate CO2 in order to neutralize the acidity. Okay, so the increased respirations here leads to respiratory alkalosis, thereby neutralizing the metabolic acidosis that's occurring in DKA. And they also have that rotting fruit smell, or we also call that alcohol or acetone breath. We have nausea also and abdominal pain. Both cases, though, are severely dehydrated. However, if you look at the level of blood glucose, DKA starts at 300. Other textbooks say it starts at 250. Look at HHS. It doesn't start until 600. And we're talking about osmotic diuresis here. So the higher your blood sugar, the more dehydrated you become. So which one of these patients, therefore, will have a poorer prognosis? Or should I say, which of these will be more dehydrated?
HHS.
HHS, obviously, because look at the blood glucose, 600. And that's just the start. Now, please do not confuse this by saying, oh, the blood sugar in DKA settles around 300. No, simply means, this table simply means that the symptoms of DKA starts at 300, over 300. They can still reach blood glucose of 1,000, 1,200, or 1,500 milligrams per deciliter, right? That only means symptoms start earlier. Symptoms here in HHS start later. Osmolarity, this is referring to the concentration of your blood. So imagine Slurpee, okay, versus a glass of plain water. So if you put Slurpee, a glass of Slurpee on one side and a glass of water on the other side, which one is more thicker?
Slurpee.
The Slurpee cup. So imagine Slurpee, your bloodstream circulating with the thickness of Slurpee. How will that affect urine output? Because now in order to neutralize the thickness of your blood, osmosis, which states water will move from an area of lesser concentration to an area of greater concentration. So therefore, if your blood sugar is high, that will increase blood volume, and this is what's responsible for the dehydration. So the cells will become dehydrated because now water moves from the cell into the bloodstream, into plasma, increasing blood volume, increasing blood pressure, increasing perfusion to the kidneys, increasing urine output. That's how osmotic diuresis occurs.
Professor,
Yes, sir.
I just have a question. All right, with the viscosity increasing, wouldn't it like impair any of the renal arteries or anything of the sort?
Say again, sir, with the
Like the viscosity, since you're saying like it's increasing because of the sugar concentration, since it's becoming more thick, the blood itself is becoming more thick, wouldn't that slow down the urine because of the thickness trying to go through the arteries and everything, or no?
no, because the blood volume automatically, remember, osmosis is a passive movement of water, right? You don't need to tell the body to where to shift the water. Because osmosis is a passive movement, the moment your sugars go high, water automatically enters the bloodstream. You don't need to tell them that. There's no stimulation needed. Again, this is an automatic passive movement of water. So it will automatically dehydrate all the cells, increasing blood flow, so you have no problems with perfusion at all.
Okay.
Okay. The pH in DKA is acidotic. What's responsible for that is the ketones now. I'll show you when we go to the pathophysiology. However, there's no such thing, no such decrease in the pH in HHS because there is no or very little, if any, ketone formation. Bicarb, because you're acidotic in DKA, of course, the serum bicarb will be below 15. Normal is between 22 to 26, right? So this is severely acidotic now. Sodium won't be technically very affected in DKA. It's really the potassium level that will be affected here. I'll show you later when we get to the pathophysiology. BUN, because in both cases though, the patient becomes dehydrated. So eventually perfusion will drop, causing kidneys to suffer acute kidney injury. So your BUN and creatinine will elevate in both conditions. And finally, there's ketones in DKA and none in HHS. Let's see, why is there no
Ketone.
ketone formation? All right, so
Yeah.
here's your pathophysiologic mechanism. So again, the patient got sick. And in the case of DKA, type 1 diabetics have absolutely no insulin. So let's say the patient got sick and then thought that my sugar will be low, so they stop taking exogenous insulin. So they assume that their blood sugar is low, which of course is not the case, but that's what they thought is happening. So they stop taking the insulin altogether, and then three mechanisms start occurring. These are all automatic because there is no insulin. However, the body has no idea that that is the problem. All the body knows is that can they get to the sugar that is in the bloodstream? Can the cells take the insulin, the sugar without insulin?
No.
No, it's impossible for glucose to enter the cell if there is no insulin. However, the cells do not know that. The cells continue to send signals to the brain saying, I'm hungry. But that is not the case. The patient here already has a blood sugar of over 300. The problem is not a lack of glucose, but rather a lack of insulin. But again, the body, not knowing what's going on, will trigger counter-regulatory mechanisms. So the body will go into a starvation mode. It will now start breaking down
Proteins.
body's sources of glucose in an effort to feed the cells. Okay, not knowing that it's not a problem of the lack of glucose. We actually have plenty. The problem is no insulin. So there becomes a vicious cycle here. This will never stop. This will only end one way. This will only end in continued increase in blood glucose levels. Okay, because there is absolutely no insulin, and then the patient has no idea. So we break down the three sources of glucose. So we start with the liver. Since that is short-lived because we only have a limited amount of glycogen, so it will now go after fat. So look at the left side, it's breaking down fat. On the right side, it's also breaking down protein. All these three will continue to raise the blood sugar levels because again, without insulin, it will not be able to enter the cell. So if you go down the left side, so once you break down fat and a lot of it, they will lead to ketone body formation, which are now turning your, your blood pH less than 7.35. On the right side, under protein, so you have muscle breakdown there because that's how we break down protein. All of these conditions will lead to hyperglycemia. It will make the osmotic diuresis worse. The patient would continue to have polyuria until they become dehydrated because they cannot drink enough fluids to sustain the dehydration. All of these coupled with acidosis eventually will kill the patient. Either they'll go into shock or go into coma first before they go into shock. Let's go to the management now. So you saw the mechanism by which the severe hyperglycemia worked and the continued vicious cycle that unless stopped, and the only way we can stop this is to give insulin, right? Go now to the interventions. Here are your interventions. Now, because the patient is dehydrated and we have severe hyperglycemia here, 300 milligrams per deciliter or more, this is an emergency. So what is our priority in any emergency life-threatening situation?
Airway.
Airway is maintained.
Right. Okay, so we start with airway, breathing, and circulation. So the patient presents to the ER looking like this. We give oxygen first. Next is your fluid. So now we administer fluids, massive amounts of it. So just follow this. We have airway, level of consciousness, hydration status, electrolytes where we're at it, and monitoring blood glucose level. If you take that one by one, that means we give oxygen, we give fluids, we replace electrolytes, and we give insulin to drop the blood glucose level in that order. Circulation.
Can you repeat that, please?
Right here. So that's, again, airway. So that means you give oxygen. Hydration, that means you give fluids and replace electrolytes and give insulin to manage the glucose level. Now, you may argue, oh, that takes a long time. What about the blood glucose? it's not like there's hours in between these. Okay, so the moment the patient's in the ER, you give oxygen right away. It doesn't take 5 minutes from when you gave oxygen to when you started fluids. Okay, it's probably less than a minute in between. Okay, you start an IV access and then start your IV fluids. And then while you're doing that, where you're waiting for labs to come back, wherein you'll need to replace electrolytes, you're also hanging insulin. Okay, let me demonstrate how this works. All right, so we give fluids because obviously this patient is severely dehydrated, right? So if you read the second paragraph, thank you for reading, Mr. Kyle.
The first outcome of fluid therapy is to restore volume and maintain perfusion to vital organs. Typically, initial infusion rates are 15 to 20 mLs per kilogram per hour during the first hour.
Okay, so the first hour, what type of IV fluid are we expecting the doctor to order?
Normal saline.
All right. So the only fluid here are crystalloids. It may be LR or normal saline, but since this is a non-traumatic dehydration, so the preferred crystalloid is normal saline. So let's say I weigh 70 kilograms. How many mLs per hour will you run this normal saline?
Is it 15 to 20?
Yep, mLs per kilogram. So how many mLs per hour will you run this thing?
1,050 minimum.
All right, so we're talking about 1 liter to 1.4 liters here, depending on the patient's weight. That's a lot of fluids for the first hour. So you can easily go through 1 liter of fluid in less than an hour. So while this thing is running, what is the second outcome? Thank you for reading, Ms. Tessering.
A second outcome of replacing total body fluid losses is achieved more slowly. The choice for fluid replacement depends on blood pressure, hydration, serum electrolyte levels, and urinary output. In general, hypotonic fluids are infused at 4 to 14 milligrams per kg per hour after the initial fluid bolus. When blood glucose levels reach 250 mg per deciliter, give 5% dextrose in 0.45% of saline. This solution helps prevent hypoglycemia and cerebral edema, which can occur when serum osmolarity declines too rapidly.
Okay, so let's review. Patient comes in, you gave oxygen, you have IV access, you hang 1 liter of normal saline. So it could be 1 to 1.5 liter, again, depending on the patient's weight. So while this is infusing, we cannot start the hypotonic solution, correct? Because this thing is still running. It says here, after the initial bolus, which is, this is your bolus, right? So this is bolus currently running. So we can't sit down and then fiddle with our fingers. We have to move on to the next goal. Again, these are our goals here. It says airway, hydration, electrolytes, and blood glucose levels. So we need to start managing
Insulin.
right while the first bag is up. So while this first bag is up, now we continue with the insulin. Okay,
Insulin.
let's finish this part first. So after that first bag of normal saline is finished, now we switch it to hypotonic, which is half normal saline now. This will be running at a much lower rate this time because we don't want to cause cerebral edema, because the sodium levels here might start to drop. Okay, I'll show you how later. And don't worry about switching to the D5 because this will probably be in the either 12 hours later or maybe even 24 hours later. Okay, because it will take time to correct the dehydration.
Oh, so you mean to say when we give 5% dextrose, that means we are managing the trying to prevent hypoglycemia, right?
Yes, but this will not happen unless you do the next thing, meaning we won't get to this page, okay? We won't get to 250 unless we do this. Are you making sense?
Unless we put the insulin, right?
We won't get to that point. This
Yeah,
is our
okay.
goal. Again, our first outcome fluid-wise, so this is all under fluid and electrolyte management. So patient comes in, we hang the normal saline, run it at a bolus rate, 1,000 to 1,500 mLs per hour, and that's for the first hour. Then while waiting for that to finish, we take care of the glucose now. So there are 2 doses of glucose here. So this is our goal. We're going to drop the sugar by 50 to 75 milligrams per hour. Thank you for reading the first dose, Miss Amanda.
Initial therapy.
Let's start with this one right here.
IV bolus dose of 0.1 unit per kilogram is followed by an IV infusion of 0.1 unit per kilogram per hour. Continuous insulin infusion is used because insulin half-life is short and subcutaneous insulin has a delayed onset of action.
All right, that's pretty clear, right? So this is all about insulin therapy. So before we give the continuous infusion of insulin, we have to give a bolus. Both are given IV. So the bolus is IV insulin, the infusion is also IV insulin. What type of insulin is the only one you can give IV?
Normal. Or regular.
Regular. So to demonstrate, let us okay, so you give 0.1 units per kilogram of insulin, right? So this is your insulin vial, so it's regular insulin. So you draw it with a insulin syringe. So you draw, if I weigh 70 kilograms and the order is to give, the standard is to give how much? 0.1 units per kilogram. So how much insulin are you giving me who weighs 70 kilograms?
7 units. 7.
Okay. Now our goal is 7. The next question is, how are you going to administer this thing IV? So you drew up 7 units here. So let's say this is 7 units in there. How do you give this thing IV?
Would it be IV push?
Yeah, how?
Would it be through the initial bolus of fluids?
If you say that, if this is the bag of NS that's burning currently, you'll have to wait until this bag is finished before the patient gets the 7 units. So we can't do that. This has to be given separately. So remember, this thing is in a syringe. Can you take off the needle of the insulin syringe? Is it possible?
Yes.
Yes.
How? You break it off?
You screw it off.
How do you screw off an insulin needle off an insulin
Oh
syringe?
no,
No, you can't screw that one off.
No, we have to use a piggy bag, you know.
So can you administer this straight IV?
No, we have to use a piggy bag with a normal saline and then
It says
dilute
IV bolus though. It's an IV push. It says clearly here. It's IV bolus. So how are you gonna give 7 units of IV bolus? Okay, so you get a flush. This is now a pre-filled syringe.
Mhm.
This is a flush. This is a lower lock, correct?
Mm.
So you empty a little bit. So this is 10 ml of normal saline. So you squeeze out maybe 1 ml and then draw back. So you add these 7 units inside that syringe. So this tip here is sterile, so you add it here. Now you have 7 units in 10 ml of normal saline. Now this is lower lock, so now you can push this. That's how you administer your insulin bolus. So you just gave your intravenous. Now comes the continuous infusion. So the order for continuous infusion is 0.1 units per kilogram per hour. So here I have a bag regular insulin, 250 units in 250 ml of normal saline. So the pharmacy sent this. So this is an IV bag. It is a small bag, 250 ml bag. Now currently this thing here is running. This is running in one line. How do you administer the continuous IV? Do you piggyback it to your primary or you run this separately?
You run separately.
You run separately.
It has to be run separately because if you do IV piggyback, that means you will stop the NS or run the insulin. Patient needs both together at the same time. So do not run it piggyback, okay? It has to run on a separate pump. So at the same time, therefore, the patient will be receiving this fluid right here because we're still in the first hour. The patient is still, where are we? The patient is still receiving this right here, this bag right here. And while that's running, you have to take care of the insulin. So first push that bolus. And now question. So if the order is 0.1 units per kilogram per hour, how many mLs per hour will you run this bolus? So this one, I'm the same patient, 70 kilograms, and the order is 0.1 units per kilogram per hour. How many mLs per hour? And this is your bag right here. 250 and 250.
Professor, can you repeat what you just said?
Well, this is your bag. The patient was given, pharmacy sent up a bag of regular insulin, 250 units in 250 ml of normal saline. We already gave the bolus, 7 units you told me. How many mLs per hour will you run the continuous infusion?
Seven mLs per hour.
7.
mLs per
7 ml per hour, right?
Right, so you just had 2 math questions there for exam 1. So that will be an example.
Yeah, 7 ml because 250 divided by 250 is 1 into 7 units, so 1. So 7.
So both are running now. The patient is receiving NS in one line and then
Professor, what was that answer?
7 mLs per hour. You have a question on how it was calculated? Any question on this one? Anyone?
No.
Basically, this one here, the concentration here is 1 unit per 1 ml.
Mhm.
And since your patient weighs 70 kilograms times 0.1 units, so that's 7 units per kilogram per hour. So times 1, 7 ml per hour.
Mm.
All right, so let's continue. So we have saline running in one line, and then we have the insulin running in the other. So we continue to monitor blood sugar because DKA is considered resolved once we hit less than 200. So the only way to know that is to monitor your sugar every 15 minutes. Now, remember this patient is DKA. So we are managing the fluids for dehydration. We're managing the blood sugar. What do we do about the acidosis? Something has to be done because otherwise this patient will continue in the Kussmaul's respiration, will continue with metabolic acidosis. Here is your answer. When do we give bicarbonate? This is your buffer. This will be used to neutralize the acidity because the patient is in severe metabolic acidosis. You give bicarbonate, IV. When is this given though? Do all DKA patients receive bicarbonate?
No, only when their pH there is less than 7.
Okay, only in severe acidosis.
Severe,
You
yeah.
don't give bicarbonate unless you hit 7 or less. Okay, pH of 7 or less, or if your serum bicarbonate is now less than 5. Okay, so we wait until it's severe. And we're not done yet because the patient still has other problems, namely, what do you remember in chapter 11? What happens if you give regular insulin IV under hyperkalemia? You remember the interventions for hyperkalemia? We had
Does it-
choices of sodium polystyrene sulfonate. We can give diuretics. We can also put the patient on dialysis. And we can also give solutions containing IV dextrose and regular insulin. Are you giving this patient regular insulin IV? Are you?
Yeah.
Yes, this patient is receiving IV insulin infusion continuously. So what will happen to the patient's potassium level?
It will decrease.
Yes. So is it a matter of if the potassium will decrease that we will replace it?
No,
When?
we will give it to prevent it.
So we do not wait for the potassium to drop. We anticipate that the potassium will drop once you start this IV insulin right here. Which is good. On the next hour, are we continuing with the normal saline?
No.
No, this is finished. So now we are on the second outcome now, which is now on hypotonic solutions now. So when you hang this half normal saline, what will be added to that bag?
Isn't it glucagon? No.
Because you know, you just told me that the potassium here will drop.
Yeah.
So what will needed to be added to this half normal saline bag?
Is it potassium?
We'll add potassium chloride into that bag because you agreed with me that it's not a matter of if. The potassium level will drop once you start giving IV insulin, correct?
Mm-hmm.
And what did you learn in chapter 11? Was it hard or was it easy to replace potassium? Was it easy to correct hypokalemia?
No.
No, because the limit, the most you can give is 10 milliequivalents of potassium chloride per hour. So once this potassium level drops, it will be extremely hard to correct it. So rather than waiting for it to happen, you be more proactive. So once you change the fluid, so normal saline is finished, you hang the half normal. This bag here, this number 2 bag, will now contain potassium in anticipation of what will happen here, because now you're going to give the patient, you are giving the patient IV insulin, regular IV insulin intravenously, continuous infusion, so it will drop your potassium. So to prevent that, we add potassium right here. Any question? That's DKA. And then you just monitor, continue to monitor until we reach here. If we reach less than 200, so this is now considered resolved. So DKA is over. And as far as the fluids are concerned, once you hit less than 250 or less, we change the fluid again. So we switch from hypotonic this time, we give D5 half normal saline. All right, and this is done for every single DKA patient. So it's nothing new. You see this once, you see it again the next time, you do exactly the same thing. You start with normal saline, you give the IV fluid bolus, the IV insulin bolus, followed by continuous IV insulin solution infusion. And then once the first bag of saline is finished, we switch to half normal saline with potassium now, because we anticipate it will drop. And then once you hit 250, the fluid again changes from half normal with potassium to now D5.5. Whether or not it contains potassium will depend on if the patient is still receiving this. So if they are, then this will also still contain potassium. If not, because your sugar is now 200 or less than 200, then the infusion of insulin stops. Are we clear?
Yes.
All right, so let's finish HHS. The prevention here, we already discussed prevention. It was under sick day rules. Okay, so to prevent DKA, tell them about sick day rules. And there are practical examples here, by the way, because I already said not all DKA patients need to be admitted, right? So to prevent them from being admitted, if they can do these, then they have to, unless these occur here, then they have to go to the hospital. But if they're not at this point yet, they can stay at home. Just stay hydrated. Okay, so here, like Gatorade, for instance. Okay, if you can't tolerate food, then drink, Glucerna. Okay,
Professor, which page are you on?
13, 14. HHS this time. This is very short because if you look at the pathophysiology, what's the only thing missing? This section right here. There is little or no ketone bodies. So therefore, what's the only thing different between the two? Is there acidosis management here in HHS?
No.
No.
No need, because there is no acidosis. So as far as fluids and electrolytes and glucose management, is it different? Is this patient still very dehydrated?
No acidosis, so that means he doesn't need a bicarbonate, right?
He's still dehydrated.
Yes, but this is still a very dehydrated patient. In fact, what is the blood sugar here? Is it better or worse than DKA?
It's worst.
It's worse. So how much fluid do you think this patient will receive?
A lot.
It the same or more than DKA?
More.
This patient will receive more. So same thing, look at the pattern. We still start with normal saline, still at a high rate. And then we reduce it to 1 to 200 ml per hour during the second hour, or especially if your urine output is now at least 30 mLs per hour, or 5 mLs per kilogram per hour. And the IV insulin, it's just slightly higher. Remember, our bolus in DKA was 0.1. Look at the bolus here, slightly higher, 0.15 units per kilogram. But your insulin infusion is still the same, 0.1 units per kilogram per hour until, again, your sugar falls below 250. Slightly higher threshold compared to DKA. DKA, we said we stop the infusion if it's less than 200, right? So here, it's less than 250. Those are the minor differences. But this is still a very dehydrated patient. So they get the same, they get normal saline, and at the same time, they get the insulin bolus, insulin infusion, and then we switch fluids again. So after normal saline, we switch to...
No.
Are you talking to me? Probably not. Okay. All right. And that's it for HHS and DKA. Any question?
Professor, how soon did you say you were going to upload the link?
I'll link to...
Earlier you were mentioning a link to either YouTube or you were going to email us, one of the sort.
Oh, this class?
Yes.
As soon as it finishes converting, and it'll probably take a couple hours because I have to wait for this thing is converting, because they'll convert it to MP4, and then I have to upload it to YouTube and then send you the link.